Now we will see the acinar variety of adenocarcinoma. So over here you can see the round to oval variety of central luminal spaces surrounded by the tumor cell. So you can see the glandular pattern over here. Okay, very important. Not only that, sometimes the gland is going to show back-to-back arrangement of the glands, giving rise to a cribriform pattern, as you can appreciate. This is another cribriform pattern. Now remember, this is one variant of acinar adenocarcinoma, but the cribriform pattern is associated with a poor prognosis. Okay, so this is the acinar variety, as we can appreciate. The next important variety is the papillary variety. You can see multiple papillas. In the center, you can see the fibrovascular cords. So the presence of the fibrovascular cords in all these papilla is suggestive of the papillary variety of adenocarcinoma. Next, we are having the solid variety of adenocarcinoma, where you see the tumor cells which are present in sheets. Okay, so over here you can see undifferentiated solid nest of tumor cells can be there, and it is in these carcinomas that TTF and or napsin stain is required. The pattern consists of polygonal tumor cells arranged in sheets lacking any recognizable lipidic, acinar, papillary or micropapillary architecture. When this architecture is not present, then we are seeing it as solid. So over here you might confuse them with a poorly differentiated squamous cell carcinoma also. So in that particular situation you have to carry out IHC. To confirm the glandular differentiation in the solid variety of adenocarcinoma, you have to carry out TTF1 plus minus napsin, and you have to give a P40 should be negative. Okay, so either of these two should be positive, especially TTF1 should be positive or napsin should be positive, and they should P40 should be negative. Along with that, you can do histochemical demonstration of intracellular mucin can be done using PASD or mucircarmine in more than equal to 5 tumor cells in each of the two high power fields. Now the TTF1 immunohistochemistry shows the diffuse nuclear staining confirming a solid adenocarcinoma. This tumor was also P40 negative. So P40 negative documentation is very important. Okay, you have to keep that in this panel. Now this is the micropapillary variant, wherein you can see these multiple small papillae are there. Okay, we can appreciate, but none of these papillae, they do not have any fibrovascular core. So again over here if you see, they do not have fibrovascular core. So this tumor consists of extensive micropapillary clusters of tumor cells lacking fibrovascular core, and this is carrying again a very poor prognosis. Myself Dr. JIBRAN presents to you Simply Pathology, and today we are back with a very important lecture. In the previous lecture, we have already seen about the precursor glandular lesions, that is atypical adenomatous hyperplasia. Along with that, we have also read about adenocarcinoma in situ. So these were the two important precursor lesions. Okay, and we had also read about minimally invasive adenocarcinoma. Today we are going to read about the invasive non-mucinous variety of adenocarcinoma, which is the most common variety of adenocarcinoma. Along with that, we are also going to read about the invasive mucinous variety of adenocarcinoma, which is a rare variety. So let us begin today's topic of discussion. So as we already know that the invasive non-mucinous adenocarcinoma is a non-small cell lung carcinoma with a morphological and immunohistochemical evidence of glandular differentiation. Adenocarcinomas are more likely to be peripherally located in the lungs as compared to the other types, okay? But tumors might also occur centrally. Remember, the term bronchoalveolar or bronchoalveolar carcinoma has become obsolete and it is no longer used. Now, the molecular alterations are thought to accumulate in a stepwise manner, as we had read yesterday that initially these mutations will occur in AAH. That will be followed by increased frequency in AIS, then in minimally invasive adenocarcinoma, and finally in invasive adenocarcinoma. So in a stepwise manner, all the mutations, they start to accumulate, and the frequency of these mutations will also increase as we are going to move across this spectrum. So basically the molecular alterations, they accumulate in a stepwise manner in the development of lung adenocarcinoma, with early alterations are identified in the pre-neoplastic lesions. So these are the pre-neoplastic lesions, that is AAH and AIS. Okay, atypical adenomatous hyperplasia, adenocarcinoma in situ. Okay, including the KROS and the EGFR. Now, growth signaling pathways that are frequently involved in the pathogenesis of lung adenocarcinomas include the EGFR, RAS, PI3K-AKT pathway, and the P53, RB, P14, STK11 growth inhibitory pathway. Now, inactivating mutations of the tumor suppressor gene TP53 occurs in approximately 45% of lung adenocarcinomas, and they are commonly smoking related. Okay, it's very, very important. So, activating mutations in KRAS occurs in approximately 20% of lung adenocarcinomas, and they are also strongly associated with smoking. So, both inactivating mutations in TP53 and KRAS mutations are associated with smoking. Okay, activating mutations involving EGFR occurs more commonly in females and in never smokers, as well as in Asians. So 70% in never smokers from Eastern Asia and 40% in never smokers of European descent versus 11% in smokers of European descent. Okay, so this is very, very important. A small subset of adenocarcinomas are also driven by genetic rearrangements such as ALK fusions. Okay, patients with these tumors are younger than those with ALK negative tumors. Okay, and other factors which are involved in the pathogenesis of lung adenocarcinoma include inhibition of apoptosis, telomerase activation, and evasion of host immunity. So we have already read about the percentages of these tumors, okay, in the molecular genetics of adenocarcinoma in the first part. We have already seen that, and over here is a revision. So around 45% is having TP53 mutation, 20% is having KRAS, both associated with smoking. Majority is also having mutation in the EGFR actually, if you see, and very importantly, those activating mutations of EGFR is associated more with females and in never smokers, and also with Asians. In Asians and who are never smokers, the incidence of this is 70% in Asians, 40% in European descent versus only 11% in smokers of European descent. Now, characteristics of EGFR mutations in lung adenocarcinoma. Now, remember that among the EGFR mutation, the two most common mutation is the point mutation at codon 858, that is the L858R, and the in-frame deletions in exon 90, which accounts for more than 90% of the case. These EGFR mutations, they are highly suggestive of lung adenocarcinoma. Among adenocarcinomas, EGFR mutations are frequently detected in cases with lipidic and papillary growth, and they are associated with TTF1 positivity. Now, genetic alterations of other major lung cancer driver genes such as KRAS, ALK, ROS, BRAF, RET, ERBB2, they are mutually exclusive of EGFR. What is the meaning of that? The meaning is, if in one tumor EGFR is present, then these other mutations will not be present. If in one mutation KRAS mutation is present, then EGFR will not be present. So they are mutually exclusive of each other. Then rare families with germline EGFR mutation, that is inheritable and inherited from the families, they have a very high risk of adenocarcinoma, which can be multifocal, particularly in the case of germline EGFR T790M mutation. Now, EGFR mutation in lung adenocarcinoma, they show ethnic difference, as we have already seen, the prevalence being 10 to 15% in people of European descent, whereas a higher incidence of 30 to 40% is seen in Asian. EGFR mutation is a prognostic factor as well as a factor predictive of response to first and second generation EGFR tyrosine kinase inhibitor treatment. So it is basically responsible, or it is, if you are getting EGFR positive, then it can improve the prognosis. So prognostically, it becomes important, for carrying out this molecular testing for EGFR. EGFR mutation in exon 20 in-frame insertions and really PT790 mutation, M mutations, these are associated with primary resistance to the inhibitor therapy, and the acquisition of an additional PT790M mutation is the most common cause of secondary resistance to the EGFR inhibitors. So these are some of the very important characteristic features of EGFR mutation in lung adenocarcinoma. Now, the characteristic of ALK gene fusions in lung carcinoma. Now, very important, ALK fusions are detected in various tumors of the lung, okay, even in thyroid, esophagus, soft tissue, kidney, colorectum, and bladder. And the fusion partner genes vary among the tumor types. So the ALK fusions can have multiple partners, but the most common one is EML4. So EML4 ALK fusion is the most frequently found and almost exclusively found in carcinomas of the lung. ALK rearrangement in lung cancer is strongly associated with adenocarcinoma histology, in particular with acinar and or solid growth pattern, or with cellular features of signet ring cell carcinoma. Now, EML4 ALK fusion accounts for more than 90% of all the ALK rearrangement, but there can be other fusion partners also. These are the other fusion partners. Like EGFR, ALK rearrangement is frequent in never smokers, but it is less associated with female sex. The median age of patients presenting with ALK positive lung cancer is 10 years younger than ALK negative lung carcinoma. ALK positive lung adenocarcinoma constitutes 4 to 5% of non-small cell lung carcinoma, and ethnic differences has not been associated. That means in both Europeans as well as in Asians, the incidence is similar. ALK rearrangement is predictive of response to ALK inhibitor treatment, but it is not a prognostic factor like EGFR. Now, macroscopically, if you look at the lung adenocarcinoma, most invasive adenocarcinomas, they appear as gray-white nodules with central scarring fibrosis associated with anthracotic pigmentation and pleural thickening. The peripheral lipidic component may result in a poorly defined border. So, just let me show you. Okay, so this, if you can appreciate, this is the gross image. So, you can appreciate a very well-defined solid nodule over here, which is presenting the invasive component actually. So the gross image is showing a solid white component corresponding to the invasive component of the adenocarcinoma. As well as you can see the adjacent very less a poorly defined area. This is corresponding to the lipidic component. Lipidic is that component which is growing along the alveolar walls, as we have seen in the previous lecture. Okay, what is lipidic? Non-mucinous lung adenocarcinoma usually consist of complex admixture of architectural patterns. So they can have different kinds of architectural pattern like lipidic pattern, acinar pattern, papillary pattern, micropapillary pattern, solid pattern, and they are classified into subtypes according to the predominant architectural pattern. Now in resection specimens, each pattern should be estimated in a semi-quantitative manner, okay, and recorded in 5 to 10% increments totaling 100%. Although it is possible to have equal percentages of two prominent components, but a single predominant component should be chosen. And when you are measuring, you should always measure in increments of 5 to 10%. Okay, in that way, it is very easy to quantitate each pattern, and you have to write one predominant pattern you have to write, and you have to mention the percentage of other in increments of 5%. Okay. So let us see the different patterns. So this is the lipidic predominant adenocarcinoma. So what is very important, we can see that this is a very big area, a nodular area can be appreciated. Now on the periphery, if you see, this is the lipidic component. Okay, what do you mean by lipidic? Now if you see, this is the normal component, but this is the lipidic component wherein there is a growth of the type 2 pneumocytes which is taking place or growing is there along the alveolar lining. Okay, invasion is not there, but this central area is the one where there is invasion, where you can see different patterns. Now remember, the invasive pattern is always in some other pattern like acinar, papillary, micropapillary, okay, solid pattern of invasion. So the invasive pattern is always different as compared to the lipidic. Lipidic pattern should never be taken into account while assessing the invasive component. So this central area, if you can appreciate, this central area, this is the invasive component, and this is basically exemplified by this particular area. So this is the lipidic predominant adenocarcinoma where majority of the tumor is in the lipidic pattern, but there are areas of invasive pattern. One very important point is that for it to be invasive, it should be more than 5 millimeter in greatest dimension. The invasive component should be more than 5 millimeter in greatest dimension. If it is less than equal to 5, then the diagnosis of minimally invasive adenocarcinoma is warranted. But if it is more than 5, then it becomes invasive. The tumor consists of predominant lipidic component and an invasive component measuring 12 millimeter. In this image, there is a central fibrous scar, as we can appreciate. This is the central area. It is invaded by acinar and solid pattern of adenocarcinoma. So over here, you will find the acinar means you will see. Can you see the small glandular structure? So these are the acinars, and there are certain areas where there is solid growth also. So both these patterns are present. Okay, and this is basically exemplifying the invasive component. Okay, in lipidic predominant adenocarcinoma, the invasive component is measuring more than 5 millimeter in greatest dimension, as we can appreciate. Now, we cannot see from here. It is under the microscope that you have to measure. Now, the invasive component is defined as a histological pattern which is other than lipidic pattern, as I am already telling you. So, the invasive, this is the invasive component, and the invasive component is other than the lipidic, because lipidic pattern is the pattern that is going along the alveolar walls. From that, you cannot gauge the invasion. The invasion is always gauged by other patterns, presence of other patterns, and the length of that and the area of that pattern is then measured. Okay. Now, for example, the acinar, papillary, micropapillary, solid, less commonly colloid, fetal, enteric, or invasive mucinous adenocarcinoma and or myofibroblastic stroma associated with invasive tumor cells. So these are the areas that we are going to see. Okay, that we are going to gauge for invasion. Now this is another diagram. The same lipidic component is the same lipidic predominant adenocarcinoma. Now on the left hand side, this is the lipidic that I was telling you. This is the lipidic component wherein you can see the growth is along the alveolar walls, and this is the solid area wherein we can appreciate the growth of these cells. We can appreciate the acinas. We can appreciate certain solid areas of growth as well. Okay, so lipidic component is on the left, is surrounded which surrounds the invasive. This is the invasive portion. So the lipidic area is surrounding the invasive portion on the right hand side with acinar and solid pattern of growth invading a fibrous stroma. A diagnosis of lipidic adenocarcinoma rather than minimally invasive adenocarcinoma should be made if the cancer is invading the lymphatic system, blood vessels or pleura, exhibits tumor necrosis, contains an invasive component more than 5 millimeter and shows the spread through the air spaces outside the tumor. Okay, so these are the 4 important differentials if you differentiate from minimally invasive adenocarcinoma. Now always remember, even if the tumor is less than 5 millimeter, less than equal to 5 millimeter, but either of these features are present, then also it becomes invasive adenocarcinoma. So now we are going to just differentiate whatever we have already read. We will differentiate minimally invasive adenocarcinoma versus the lipidic predominant adenocarcinoma. So the size of the total tumor is usually over here is less than 30 millimeter or less than equal to 3 centimeter. Whereas over here the size can be any. Okay, the tumor that otherwise meets the criteria for minimally invasive adenocarcinoma, if all the features of MIA is present, but along with that the tumor is more than 3 centimeters, then again it will be taken as invasive variety. The size of the invasive focus is less than equal to 0.5 centimeter or 5 millimeter. Over here it is more than 0.5 centimeter. Over here less than equal to. The invasion of the pleura, blood vessels or lymphatic space should be absent, whereas it may be present over here. Tumor necrosis should be absent. It is present over here. Spreads through the air spaces, it is absent. It may be present. So this is how you differentiate between minimally invasive adenocarcinoma versus lipidic predominant adenocarcinoma. Then we are having the features which helps to distinguish lipidic pattern of adenocarcinoma from invasive adenocarcinoma. Now, lipidic predominant adenocarcinoma can also be differentiated from pure invasive variety. How? The histological pattern in the lipidic variety is lipidic, but over here in the invasive variety, you can have acinar, papillary, micropapillary or solid variety. The stroma, myofibroblastic stroma is usually absent over here, but it may be present in invasive variety. Intraalveolar macrophages, they may be present, but usually they are absent over here. Okay, intraalveolar macrophages. Alveolar architecture is quite preserved, as you can appreciate. This is the lipidic predominant and the alveolar architecture yet is preserved. You can see over here in this diagram. Whereas in the invasive variety, it is lost. Okay. Now we will see the acinar variety of adenocarcinoma. So over here you can see the round to oval variety of central luminal spaces surrounded by the tumor cell. So you can see the glandular pattern over here. Okay, very important. Not only that, sometimes the gland is going to show back-to-back arrangement of the glands, giving rise to a cribriform pattern, as you can appreciate. This is another cribriform pattern. Now remember, this is one variant of acinar adenocarcinoma, but the cribriform pattern is associated with a poor prognosis. Okay, so this is the acinar variety, as we can appreciate. The next important variety is the papillary variety. You can see multiple papillas. In the center, you can see the fibrovascular cords. So the presence of the fibrovascular cords in all these papilla is suggestive of the papillary variety of adenocarcinoma. Next, we are having the solid variety of adenocarcinoma, where you see the tumor cells which are present in sheets. Okay, so over here you can see undifferentiated solid nest of tumor cells can be there, and it is in these carcinomas that TTF and or napsin stain is required. The pattern consists of polygonal tumor cells arranged in sheets lacking any recognizable lipidic, acinar, papillary or micropapillary architecture. When this architecture is not present, then we are seeing it as solid. So over here you might confuse them with a poorly differentiated squamous cell carcinoma also. So in that particular situation, you have to carry out IHC. To confirm the glandular differentiation in the solid variety of adenocarcinoma, you have to carry out TTF1 plus minus napsin, and you have to give a P40 should be negative. Okay, so either of these two should be positive, especially TTF1 should be positive or napsin should be positive, and P40 should be negative. Along with that, you can do histochemical demonstration of intracellular mucin can be done using PASD or mucercarmine in more than equal to 5 tumor cells in each of the two high power fields. Now the TTF1 immunohistochemistry shows the diffuse nuclear staining confirming a solid adenocarcinoma. This tumor was also P40 negative. So P40 negative documentation is very important. Okay, you have to keep that in this panel. Now this is the micropapillary variant wherein you can see these multiple small papillae are there. Okay, we can appreciate, but none of these papillae, they do not have any fibrovascular core. So again over here if you see, they do not have fibrovascular core. So this tumor consists of extensive micropapillary clusters of tumor cells lacking fibrovascular core, and this is carrying again a very poor prognosis. Now this is again an acinar variety of adenocarcinoma. Now sometimes what happens that you will have multiple patterns which are present within an adenocarcinoma. So for example, you have acinar or papillary or micropapillary pattern, or not micropapillary, you have acinar, you have papillary pattern. Okay, you will have, so these patterns when they are present, but along with that you also see small micropapillary. Okay, then in this situation we should again classify it as micropapillary. Even if the acinar pattern is more predominant, we should classify them as micropapillary. Why? Because the presence of even very less amount of micropapillary carcinoma or variety of this pattern, okay, it portends a very poor prognosis for the patient. So that is why very important, even if other patterns are present and along with that this micropapillary is there, you should always state the presence of micropapillary and they should be classified as micropapillary because they portend a very bad prognosis. Okay, as we can see that this is the acinar over here, this is the acinar pattern as we can appreciate, and over here a micropapillary pattern is also there within the acinars. Okay, so basically this should be classified as micropapillary pattern because they have a bad prognosis. Now coming to the immunohistochemistry, IHC can be a useful ancillary technique to confirm the primary lung adenocarcinoma rather than pulmonary metastasis, and is also required for diagnosis of solid predominant lung adenocarcinoma, okay, or to make a diagnosis of non-small cell lung carcinoma, favor adenocarcinoma in a biopsy or cytology specimen. So in that case we have to carry out IHC. So pneumocyte markers TTF1 and napsin, okay, so these are positive in majority of the cases, 75 to 80% of the cases, and TTF1 is recommended when a limited panel is used. Double positivity in the same tumor for TTF1 and P40 usually indicates an adenocarcinoma, although adenosquamous carcinoma should also be considered in the situation. So even if both of them are coming positive, we should primarily think about adenocarcinoma in that situation or adenosquamous carcinoma. Okay, this is what we should see. Now tumors other than lung adenocarcinomas, they also express the TTF1. Okay, tumors other than, for example, if you see neuroendocrine tumors, around 50 to 60% of the neuroendocrine tumors are also TTF1 positive. Thyroid tumors, they are also TTF1 positive. Some female genital tract carcinomas are also TTF1 positive. Napsin is positive in renal cell carcinoma. So while you are interpreting them, you should always keep in mind that there are some other tumors also which are positive for them. CK7 as is given, it is not a specific marker for pulmonary adenocarcinoma. So when is it that you are going to use IHC for TTF and napsin? Number one, for pulmonary, to rule out pulmonary metastasis. Number two, in solid predominant lung adenocarcinoma. Number three, when there is an undifferentiated tumor in a small biopsy or cytology specimen. These are the three important indications for carrying out IHC. Now, grading of these adenocarcinoma, the predominant histological pattern of lung adenocarcinoma associated with prognosis, okay, with lipidic predominant adenocarcinoma having the best prognosis, acinar and papillary predominant tumors having an intermediate prognosis, and the solid predominant and the micropapillary predominant tumors having the worst prognosis. Now, if you look at the WHO grading of early resected invasive non-mucinous lung adenocarcinoma, if you see the grade 1 tumor that is well differentiated, it is called lipidic predominant with no or less than 20% high grade pattern. Okay. Moderately differentiated where they are having an acinar or papillary predominant with no or less than 20% high grade pattern. Poorly differentiated, any tumor with more than equal to 20% high grade pattern. High grade pattern means presence of solid, micropapillary, cribriform or complex glandular pattern. So this is basically the grading system for early stage invasive non-mucinous lung adenocarcinoma. Coming to the prognosis and the prediction of the tumor, As in the case for other histological types of cancer, TNM staging, it is the most important prognostic factor, very, very important. Never smoker status and female sex, they are favorable prognostic factors, independent of the stage. Tumor size more than 2.5 centimeters and solid and micropapillary patterns are associated with a poor prognosis. Prognosis for stage 1 lipidic predominant adenocarcinoma is excellent. Tumor showing, spread through air spaces, they are associated with a poor prognosis. Lung tumors frequently have a driver mutation, among them EGFR, ALK1, ROS, RET rearrangements, MET exon 14 alterations, BRAF V600E mutation. They are strongly correlated with probabilities of response to therapy. Therefore, prognostically, they become very important. Immune checkpoint inhibitors such as anti-PD1 or PD-L1 antibodies improve survival of a subset of advanced lung cancer patients, including patients with adenocarcinomas. Now we are going to read about the invasive mucinous adenocarcinoma of the lung. So we have already read about the more common variety of invasive adenocarcinoma, that is the non-mucinous variety. Now we are going to read about the less common or the rare variety of adenocarcinoma, that is the invasive mucinous adenocarcinoma of the lung. Invasive mucinous adenocarcinoma is a primary lung adenocarcinoma with tumor cells showing goblet cell or columnar cell morphology with abundant intracytoplasmic mucin. Now, invasive mucinous adenocarcinomas are located peripherally in the lung and they have a high frequency of multifocal, multilobar and bilateral tumors which may reflect erogenous spread. Invasive mucinous adenocarcinomas are less common than non-mucinous adenocarcinomas, accounting for 3 to 10% of lung adenocarcinomas. Invasive mucinous adenocarcinomas are frequently associated with exposure to tobacco smoke and the etiology is similar to that of non-mucinous adenocarcinomas. Invasive mucinous adenocarcinomas develop through acquisition of genetically distinct driver mutations. Most commonly, they involve KRAS oncogene. So, KRAS mutation is very important in the non-mucinous variety, around 60%. So, unlike in the non-mucinous lung adenocarcinoma, remember TP50 mutation is rare over here, and the tumor mutation burden is generally low even in smokers. Now, in those without KRAS mutation, oncogenic fusions are frequently found, especially in never smokers, and most commonly involve NRG1, leading to activation of PI3K-AKT pathway. So, most commonly 60% KRAS is there. TP53, if you see, is rare, and oncogenic fusions involving NRG is very common in those that do not have KRAS or in never smokers. Macroscopically, these are poorly circumscribed lesions. The most important thing that clinches the diagnosis is the gelatinous or mucoid appearance on the cut section. They may be disseminated nodules or a diffuse pneumonia-like consolidation across large areas or whole lobes. Now, if you look at the histopathology, the tumor cells, they show goblet and or columnar cell morphology with abundant intracytoplasmic mucin and small basally oriented nuclei. Nuclear atypia is usually inconspicuous or absent. The surrounding alveolar space is often mucin filled. Although invasive mucinous adenocarcinoma often shows lipidic predominant growth, extensive sampling usually reveals invasive focus including acinar, papillary, micropapillary, solid or cribriform growth pattern. Now, the tumors with a mixture of mucinous and non-mucinous components should be classified as mixed invasive mucinous and non-mucinous adenocarcinoma if there is more than equal to 10% of each component. So, this becomes very important. Immunohistochemically, remember, they express CK7 and they may show focal co-expression of CK20 and or CDX2, but are usually negative for TTF1 and napsine. Now, HNF4 alpha and GATA6 have recently been described in this type of adenocarcinoma, but neither of these markers, they are not specific. Now, grading, if we see, there is no established grading system for invasive mucinous adenocarcinoma. Like we were having one for invasive non-mucinous, we do not have any established grading system for invasive mucinous adenocarcinoma. Now, the commonest molecular alteration, as we have already seen, is KRAS mutation. Unlike in non-mucinous adenocarcinoma, EGFR mutations, they are rare. Over here, oncogenic fusions that are mutually exclusive with KRAS. Mutually exclusive means in those patients that are having KRAS, oncogenic fusion will not be present, and in those patients where oncogenic fusion is present, KRAS will not be present. It occurs in 12% of cases and they provide therapeutic targets. Prognosis and predictions, if you see, the prognosis of IMA, previously it was considered to be worse as compared to invasive mucinous variety. But now if you see in the latest edition, they have said that both of them, they are having similar outcomes. Okay. This is the invasive mucinous adenocarcinoma. Now, what is very important, if you look at the histology, all the patterns can be there that we were seen in the invasive non-mucinous, but very important is the type of cell differs. Over here, you are having a cell which is columnar, apical, mucin is present, and basally located nucleus is there. If you can appreciate over here, this thing is very, very important, as we can appreciate over here, as we can see. So, columnar mucinous cells with minimal cytological atypia growing in a lipidic growth pattern. Tumor cell shows abundant apical cytoplasmic mucin and small basally oriented nucleus. So this is what we see over here, invasive mucinous adenocarcinoma. Over here again we can see the immunohistochemically positivity for HNF4 alpha, as you can appreciate over here. So with this we have completed the lung adenocarcinoma in details. Thank you very much for watching this particular video.